Respected my teachers, colleagues, and seniors, I, Dr. Shouvik Das, first year PGT, Department of Physiology, Border Medical College, I going to discuss regarding the descending tract or motor tract in brain and the spinal cord. Then first the definition. The definition of descending tract are the group of myelinated nerve fibers and that carries the motor information from the brain or brainstem to the effector muscles via the spinal cord. They can be functionally divided into the two groups. One is pyramidal group and another is the extra pyramidal groups. But in Berne, they are discussing about the regarding tract. It is another way of classifying the motor pathway on their basis of their sites on termination in the spinal cord and the consequences differences in their roles in the control of the movement and the postures. They subdivide the lateral pathway which terminates in the lateral portion of the spinal cord's gray matters, and the lateral pathway can excite motor neuron directly, although interneuron are their main target. They influence reflex arc that control fine movement of the distal end of the limbs as well as those that activate supporting musculature in the proximal end of the limbs. Another groups is called medial pathway. This medial pathway ends in the medial ventral horn of the medial group of interneurons. These interneurons connect bilaterally with the motor neurons that control the axial musculature and thereby contribute to balance and posture. They also contribute the control of proximal limb muscles movements. Then regarding the cerebral cortex, we know that there is a central sulcus, and in front of central sulcus there is a primary motor cortex, supplementary motor cortex, and the premotor cortex. And the descending tract are the motor tract which carries information from cerebral cortex to downwards. And we also know that the sensory there are some the sensory tract or ascending tract which carries sense information from carry up. Then regarding the descending tract, this is the traditional way of classification, but this type of classification is not nowadays used, and it is more problematic to discuss regarding pyramidal or extra pyramidal. So thus the classification system is already discussed in the previous slide. Though it is traditional, it is discussed regarding pyramidal system. In case of corticospinal tract, there are two. One is the lateral corticospinal tract, another is the ventral corticospinal tract, and another is the corticobulbar tract. And extrapyramidal, they are originated cortically or subcortically, and these are also subdivided by rubrospinal, vestibulospinal, reticulospinal, tectospinal, and olivospinal. But in modern classification, according to the Berne, they subdivides under heading of lateral system and medial system. In case of lateral system, they consist of lateral corticospinal and corticobulbar tract and rubrospinal tract. And in case of medial system, they contribute the pontine reticulospinal tract and medullary reticulospinal tract, lateral and medial vestibulospinal tract, and also tectospinal tract. These are classification on the basis of lateral and the medial system according to Barnleby. Then corticospinal tract. Corticospinal tract, it is also named as pyramidal tract because the descending motor pathway traditionally we divide as a pyramidal and extrapyramidal, and this corticospinal or pyramidal tract is the sign and of this disease is originally attributed to the loss of the function of the pyramidal tract. It is so named because the corticospinal tract passes through the medullary pyramid. However, in many cases of pyramidal tract disease, the function of other pathway are also altered, and most signs of pyramidal tract disease are apparently not caused solely by loss of corticospinal, but also reflect the damage to additional motor pathway. Anyway, these are site of origin are 30% contributed by primary motor area 4 and 6, premotor area and primary somatosensory area, and there is originated from the giant cell of the base. The giant cell of the base, it is the giant pyramidal cell with the cell body of 120 micrometer, and the other area, that is the layer 5. From the information regarding the layer 5, we know that there is physiological anatomical classification of cerebral cortex, mainly neocortex. This consists of the 6 layers. Layer 1 is the molecular layer, layer 2 external ganglion layer, layer 3 external pyramidal layer, layer 4 internal granular layer, and the layer 5, this layer, internal pyramidal layer, is dominated by large pyramidal cells. These cells are the main source of cortical efferent to most subcortical area. So this is the layer 5. Then course and termination. We know that there is corona radiata by which the neurons converge via internal capsule. From internal capsule, it passes through cerebral peduncle and broken into discrete bundle by pontine nuclei, and at the lower border of the pons, it reorganized into compact bundle. And from pyramids on anterior medulla, it is 80% is crossed fiber. These synapses with anterior horns cells of spinal cord, it is called lateral corticospinal tract, and 20% is uncrossed fiber. It disappears at the thoracic level of ventral corticospinal tract. and the area 4, that is the Broadman area 4 and 6, these are the two sides from which maximum primary motor cortex and the premotor cortex, this information is passed, descend down, and it extend up to the target levels. And these target levels, the lateral corticospinal tract descend until about the fourth sacral segments, and lateral corticospinal tract is somatotopically organized, such as axon designated for spinal segments intervening the upper limbs are located more medially. Ventral corticospinal tract descends up to the mid-thoracic level, and near their termination, most of the fiber tract crosses the medial plane to synapse on the contralateral neurons. So, the ventral corticospinal tract at the level of spinal interneurons supply the proximal muscles, and the fibers which are decussate at the pyramids, which called the lateral corticospinal, which are 80% of the fibers, they crossed fiber, these are directly supplied to the distal muscles through anterior horn cells. These are the corticospinal tract. These are discussed about the 80% and the 20%, the decussation, the pyramidal decussation of the 80% and the 20% of the fibers, the lateral corticospinal and the ventral corticospinal. This is the schematic diagram. Then the function. Function, ventral corticospinal tract, which control gross voluntary movements like walking and climbing, and lateral corticospinal tract, they are responsible for fine skilled movement like writing and drawing. So these lateral corticospinal, these are 80% fibers, and these are the medullary decussation. And number 3 function, it facilitates superficial reflex, and it also facilitates the muscle tone. Then corticobulbar or corticonuclear tract. These are origin from the motor cortex and the termination at the cell bodies of the cranial nerves, and course descent along with pyramidal tract and cross to opposite side throughout the brainstem and synapse with the cranial nuclei. Function, this act as a upper motor neuron type of lesion for 3, 4, 5, 6, 7, 9, 10, 11, 12, except 8 cranial nerve. And the lesion are affected in case of bulbar paralysis. Here, the upper motor neuron, that means these type of neural lesion are those in the cortex and the brainstem, and that activate the lower motor neurons. Upper motor neurons are two parts. One is pyramidal system and is the extrapyramidal system. In case of the upper motor type of lesion, there are two types of lesion occur. One is the lesion of the corticospinal tract, like pyramidal tract lesion. These are represents as Babinski sign. Babinski sign is present. Superficial reflex like abdominal reflex, cremasteric reflex are absent, and loss of performance of fine skill voluntary movements, and lesion due to extrapyramidal tract. There is a severe paralysis, little or no muscle atrophy except secondary to disuse. Number 3, exaggerated deep muscle reflex and clonus, hypertonicity of the muscle, and calf's knife reaction. These are the features of upper motor neuron lesion. Then extrapyramidal tract. Extrapyramidal tract are the motor tract not take part in the pyramidal system. This includes rubrospinal, vestibulospinal, reticulospinal, and the tectospinal. And these motor pathways are complex and multisynaptic, and it regulates mainly axial muscles that maintain balance and posture. Number 2, muscle controlling coarse movement of the proximal portion of the limb, and head, neck, and eye movement. This subdivides under heading of 5: rubrospinal, tectospinal, vestibulospinal, reticulospinal, and olivospinal. Then rubrospinal. Rubrospinal, these are originated from the red nucleus in midbrain, mainly the magnocellular portion of the red nucleus located in the midbrain tegmentum. These fibers decussate in the midbrain, descend through the pons and medulla, then take up a position just ventral to the lateral corticospinal tract in the spinal cord. They preferably affect motor neurons controlling the distal musculature, as do the corticospinal fibers. Red nucleus neurons receive input from the cerebellum and from the motor cortex, thus masking this an area of integration of activity from those of two motor system. Then tectospinal tract. Tectospinal tract, these are under medial system. Rubrospinal tract is under lateral system in modern classification. In the medial system, there is a tectospinal. Tectospinal tract originate in the deep layer of superior colliculus. The axon crosses to the contralateral side just below the periaqueductal gray PAG, periaqueductal gray matter. Then they descend in the ventral funiculus of the spinal cord to terminate on the medial group of interneurons in the upper cervical spinal cords. And the tectospinal tract regulate head movement in response to visual, auditory, and somatic stimuli. Then come to another tract. It also under the medial system. This is the ventral vestibulospinal tract. This arises in the vestibular nucleus. It is called the Dayton nucleus in the lower pons, and it descends through medulla to the spinal cord, lateral to the pyramidal tract, and it terminates on the anterior horn cell, and it extends up to the upper thoracic segments. And this is the lateral vestibulospinal. These are also originate in the Dayton nucleus. Its course descend through the medulla in the spinal cords, lying anterior to the rubrospinal tract. It terminates on anterior horn cells, and function. They form a pathway for impulse from cerebellum and the labyrinth to the spinal cord, and regulate muscle tone and equilibrium. And in this case, the Dayton nucleus, the lateral vestibulospinal tract originates in the lateral vestibular nucleus. This lateral vestibular nucleus is called the Dayton nucleus. And the lateral vestibulospinal tract excites motor neurons that supply extensor muscles of the proximal part of the limb, and that are important for the postural control. In addition, this pathway inhibits the flexor motor neurons because it also excites the reciprocal group of 1A interneurons that receive group 1A input from extensor muscle, which in turn inhibits flexor motor neurons. Then reticulospinal tract. Reticulospinal tract also under broad heading of medial system. This reticular spinal tract, these are under pontine and medullary reticulospinal tract. Origin from the reticular formation of the pons and the medulla, and the cells that give rise to the pontine reticulospinal tract are in the medial pontine reticular formation, and the tract descend in the ventral funiculus, and it ends on the ipsilateral medial groups of interneurons. Its function is to excite motor neurons to the proximal extensor muscles to the support posture, and medullary reticulospinal tract arise from neurons of the medial medulla, particularly those of gigantocellularis reticular nucleus. These tract descend bilaterally in the ventral lateral funiculus, and they ends mainly on the interneurons associated with the cell groups of medial motor neurons, and their function is already discussed. It is mainly inhibitory. Then olivospinal. Olivospinal, this originates from inferior olivary nucleus, and the course is from thalamus to inferior olivary nucleus and to the spinal cords, and it function mainly arising due to the proprioception. This ends regarding the organization of motor function, regarding the descending motor pathway, and the classification of descending motor pathway under heading of lateral system, lateral corticospinal and corticobulbar, which originates mainly by the layer 5 and the giant pyramidal cell of the base, in summary. And There is also the rubrospinal tract. It is on also under lateral system, and in and under medial system there is a pontine and the medullary reticulospinal tract, lateral and the medial vestibulospinal tract, and the tectospinal tract. This is ends the my discussion regarding descending motor pathway. Thank you. Thank you to all. Thanks for listening. Thank you.